Hello everyone. I will be covering your GI pharmacology, and today we'll start with your topic, which is antiemetics. So before we move on into your general pharmacology of your drugs in your antiemetics, we must know what emesis is. So vomiting, which is also known as your emesis. Okay. So, vomiting, as you all know, is generally a forceful expulsion of your contents of your stomach through your mouth, and also sometimes your expulsion from your stomach may come out through your nose as well. The tendency or your feeling that you generally have, or you feel like vomiting, is known as nausea, and which normally precedes, okay, which normally arises before you vomit, but it does not generally mean that whenever you have a tendency or whenever you feel nauseated you are definitely going to vomit is not always the case. So you may just have a feeling of nausea, and that feeling may not end up in vomiting as well. Okay, so what emesis is basically vomiting. Okay, so normally your nausea and vomiting generally occurs due to many conditions, and one of your most common condition is because of your stimulation of your vomiting center. Okay, whenever there is stimulation of your vomiting center, and this vomiting center is generally present in your medulla oblongata of your brain. So when your vomiting centers of your medulla oblongata gets activated, then you have your emesis occurring. Okay, so let's see your input. Since your vomiting center is present in your brain, that is in your medulla oblongata, it needs to receive certain signals to activate those. So generally there are five sources from which you get an input into your vomiting center. First and foremost, okay, the first one is your chemoreceptor trigger zone. This chemoreceptor trigger zone is present outside your blood brain barrier. Okay, your brain is protected by a blood brain barrier, but this chemoreceptor trigger zone is present outside your blood brain barrier. So since it is present outside a blood brain barrier, this chemoreceptor trigger zone is generally it is activated by your compounds or drugs or toxic substances that is present in your blood. Okay, it is outside a blood brain barrier, so it will monitor your blood as well as your cerebrospinal fluid for your toxic substances. So whenever these toxic substances goes and activates your chemoreceptor zone, which has different receptors such as your dopamine receptors, serotonin, that is your 5-HT3 receptors, opioid receptors, as well as your acetylcholine receptors, your chemoreceptor trigger zone gets activated, and this chemoreceptor trigger zone sends an impulse to your vomiting center, which induces your process of vomiting. Okay, second input where it gets is from your cranial nerve 10. Now this cranial nerve 10 generally is present in your pharynx. Okay, so you must have noted whenever you insert your finger inside your mouth, right, inside your mouth, deep inside your mouth, you feel a gag reflex. Okay, now this gag reflex is activated because of is activated because of your afferent activation of your cranial nerve 10, and then a signal is sent due to which it goes and activates your vomiting center, and then you get your tendency to vomit. So third input, okay, if you see over here, you see your third input is from your vestibular system. No, normally this is from your vestibulocochlear nerve. This vestibulocochlear nerve is present in your ear, and it is helpful, or it plays a major role in case of your motion sickness. So whenever you are going traveling in a car, right, many people they get motion sickness. So due to this, normally this occurs due to activation of your histamine receptors and your muscarinic receptors, now which sends an impulse to your vomiting center, and then you get your vomiting. Fourth one is through your vagal and enteric nervous system. Normally this vagal and enteric nervous system, they are your efferent neurons. Okay, so they are your efferent neurons which gives an input or which transfers an impulse from your gastrointestinal system, that is from your GIT, gastrointestinal tract. So if there is any irritation in your gastrointestinal mucosa by any cause such as your chemotherapy, radiation, distension, or even acute infection such as your gastroenteritis, it will activate your 5-HT receptor, and this 5-HT receptor will carry your impulse, irritating impulse goes to your vomiting center, and then it induces your process of vomiting. And lastly, you have your mediation of your vomiting center through your higher centers, so generally through your cerebral cortex. Okay, normally cerebral cortex, whenever you see a disgusting sight, smell something that is very disgusting, this also activates your vomiting center, which induces your emesis. Okay, so let's see. So in this case, you have your vomiting center, which is present in your medulla oblongata. So if you see, you have your cerebral cortex, one of your inputs that is coming. So cerebral cortex, it is, so any smell that you get, so any sight that is very disturbing, or any thoughts, okay, or under stress as well, it can activate your vomiting center present in your medulla oblongata and cause your process of emesis to occur. Sorry. Second is chemoreceptor trigger zone. I already told you chemoreceptor trigger zone is present outside a blood-brain barrier. Since it is present outside a blood-brain barrier, it can receive your signals from your blood through your, which is being provided by your toxic substances, and checks it. So if your toxic substances are present in your blood, it can induce a process of vomiting. Okay. Third is from your vestibular nuclei. This is generally from your ears, your nerve that is arising from your ears, vestibule cochlear nerve. Okay, so this nerve sends an impulse from your ears to your vomiting center whenever you are under motion, and thereby it can induce your vomiting. And lastly, you have from your pharynx and GIT. Pharynx, when we talk about pharynx, it is all about your gag reflex that you get. And when we talk about your GIT, any irritation that is occurring in your gastrointestinal tract, either due to chemotherapy, radiation therapy, or any infections in your GI tract, can induce, I can send an impulse to your vomiting center and then induce your vomiting. Okay, so generally your receptors, different receptors present for different zones or areas. Okay, now you can see your different receptors. Okay, so this is another schematic diagram showing you how vomiting is induced. Okay, so if you can see local irritants, blood-brain emetics, they can also go and act on your chemoreceptor trigger zone, induce vomiting. Irritants in your stomach can activate your 5-HT3 receptor and induce your emission or emesis. Pharynx, in case of your pharynx, whenever there is gagging, gag reflex can go and act on your solitary tractus nucleus, having different receptors, which in turns then send an impulse to your emetic center or your vomiting center. Whenever your higher center, when you talk about your higher center, it is all about your thought, sight, and any smell will induce your vomiting by activating your vomiting center. Lastly, you also have your inner ear, that is in case of your vestibulocochlear nerve, sending an impulse from your ear due to motion to your vomiting center and then inducing vomiting. Okay, so this is a schematic diagram of all that we have talked about just before this. So now different chemical transmitters and receptors that are involved in vomiting, okay, which helps in induction of your vomiting. So different differences. For first one is acetylcholine, So from your acetylcholine, it acts on your muscarinic receptor, M1 receptors, and other muscarinic receptors. Since your brain has numerous amount of muscarinic receptors, there are different muscarinic receptors involved. Second is dopamine, that is your D2 receptors. Now D2 receptor can be found in your brain as well as it is found in your gastrointestinal tract as well. Histamine receptors. Okay, now histamine receptors, different location again. Serotonin receptors, substance P, generally acting through your receptor, that is your neurokinin receptor 1, and opioids through your opioids receptors. So these are different chemical transmitters and your receptors which can induce your process of vomiting. Okay, now we'll move on to your emetics. So before going on to your antiemetics, we'll talk about your emetics. So what are emetics? So emetics are your drugs which are used to evoke vomiting or which will induce vomiting. So generally there are two types of emetics that are used. Number one, first one is which acts on your chemoreceptor trigger zone. So your drug is apomorphine. So what is apomorphine? Apomorphine is generally given through your IM or SC route. Okay, it is not given through your oral route because for your oral route a very high dose is required and your response is not so is very irregular in response. So generally your preferred is choices by your IM and SC route. Now what is apomorphine? Apomorphine is semi-synthetic derivative of your morphine. Okay, so what is apomorphine? Apomorphine is semi-synthetic derivative of your morphine. And where does it act? It goes and it acts on your dopamine. This is your dopaminergic agonist. Okay, so it goes and it acts on your dopamine receptor. Since it is an agonist, it is going to activate your dopamine receptor. So generally it activates your dopamine receptor in your chemoreceptor trigger zone. So going and activating your dopamine receptor causes what? It induces vomiting. Okay, so your mechanism also we talked about. And generally this apomorphine is not to be used if there is any depression in your respiration. So it is not to be used whenever there is any depression in your respiration, because this drug itself, apomorphine itself, can induce your, it is in itself a respiratory depressant as well as a CNS depressant. So if a patient is suffering from depression in respiration, it is not to be used. Okay, second is your ipecacuanha. This drug, okay, is less dependable than apomorphine, and your antiemetic effect being produced by ipecacuanha is highly non-reliable as well. But in comparison to apomorphine, it is far more safer. It is safer than apomorphine. Okay, your ipecacuanha, it acts by two mechanism. Number one, it acts reflexly. When we say reflexly, it means it goes and it irritates your gastrointestinal tract. Since it irritates your gastrointestinal tract, it goes and it activates your 5-HT3 receptors. It due to activation of your 5-HT3 receptors, it sends an impulse to your chemoreceptor trigger zone. To your vomiting center. Since it goes and it activates your vomiting center, it induces vomiting. Second is it goes and it acts directly on your CTZ. It activates your CTZ. CTZ sends an impulse to your vomiting center and then you vomit. So this is all about your emetics. So emetics are generally drugs which are used to induce your vomiting. Okay. Now different classes of your antiemetic drugs. So when you talk about different classes of your antiemetic drugs, there is your serotonin 5-HT3 antagonist, there is D2 antagonist, anticholinergics, H1 antihistaminics, neurokinin 1 blocker, and prokinetics. Okay, these are generally your classes of antiemetic drugs which are used for you to stop your emesis. Okay, so again same classification. Okay, anticholinergic, H1 antihistaminics, neuroleptics, prokinetic drugs, 5-HT3 antagonist, neurokinin 1 receptor antagonist, and adjuvant and antiemetics. Okay, so these are all your classification. So first we go to your anticholinergics. Okay, so your drug is a hyoscine. Okay, this is anticholinergic drug. Okay, your drug is hyoscine. Hyoscine is also known as a scopolamine. Scopolamine. Okay, so it is also known as a scopolamine. Okay, this is AMINE. Okay, it is also known as scopolamine. It is a muscarinic receptor antagonist. Okay, it is muscarinic receptor antagonist, and it is this drug is the most effective drug for motion sickness, but it has a very short duration of action. Okay, again I'm telling you, it is a muscarinic receptor antagonist. It is your most effective drug for your motion sickness, and it produces a brief duration of action. Since it is an anticholinergic, your side effects, it is similar, which you already know. It produces sedation, dry mouth is there, and other anticholinergic effects. All your side effects that you see in anticholinergics, you see the same side effects here as well. So main mechanism of how it stops your emesis is, so generally you have your vestibular apparatus. Okay, your sensory system present in your ear, and this has to send impulse to your vomiting center. So what your hyoscine does is it blocks your conduction of your nerve impulse across your cholinergic link. So since it blocks your conduction of your nerve impulse, your vomiting center does not get any impulse whenever you are under motion, so you do not get any vomiting. Now in case of hyoscine, okay, since it produces a higher amount of side effect and your duration of action is very less, what has happened is they have developed a transdermal patch has been developed. Okay, so because of your transdermal patch being developed, what happens is it gives you a longer duration of action and it produces less side effects as well. Okay, so this is all about your hyoscine. Next we move on to your H1 antihistaminic. So H1 antihistaminics, their action is generally performed by, so it is going to block your H1 receptor. Along with blocking a H1 receptor, it also has certain anticholinergic action as well as weak dopaminergic action. So since it is H1 antihistaminics, they also produce certain sedative as well. Okay, so anticholinergic action is there, antihistaminic action is there, as well as weak dopaminergic action is also being seen. So when we talk about your promethazine, diphenhydramine, and dimenhydrinate, these drugs, okay, these drugs are older classes of sorry, promethazine, diphenhydramine, and dimenhydrinate. Okay, these drugs are used for your motion sickness. Okay, and they give your duration of action for around 4 to 6 hours. So your side effects of these drugs are sedation and dryness of mouth. So okay, promethazine and phenothiazine, they also have weak central antidopaminergic action as well, and the combination of these three drugs, it is used for your CINV. This is chemotherapy induced nausea and vomiting. CINV is chemotherapy induced nausea and vomiting. Most important role or most important use of your H1 antihistaminic drugs is also for your motion sickness. Though it is used for your motion sickness, I'll again tell you most preferred drug is hyoscine. Okay, but the best one is hyoscine only. Okay, it is used for motion sickness, and it is used in very less amount for your post-operative nausea and vomiting as well. Going back to your drugs, okay, if you we are talking about H1 antihistaminic, okay, there is a drug which is your doxylamine. Okay, okay, this drug, okay, this drug doxylamine, this drug, it has a tendency to produce sedation because of its H1 antihistaminic role, as well as it has certain anticholinergic activity as well. Okay, doxylamine, it produces its action through H1 antagonism, so because of that there is slight sedation being produced, as well as it has certain role in certain anticholinergic activity as well. So your combination of doxylamine and your pyridoxine, okay, I hope you guys know what pyridoxine is. Pyridoxine is vitamin B. Okay, you must be knowing, so I'll let it be like that only. Okay, so doxylamine along with pyridoxine, which is vitamin B dash. Okay, find it out yourself. This combination is your best combination for your treatment of morning sickness. This is your first line treatment of your morning sickness. Okay, that is your doxylamine and your pyridoxine. Okay, and there is another drug which is your meclizine. This drug meclizine produces less sedative action than compared to other drugs, and your duration of action is very high. So it produces duration of action near around 24 hours, because of which this drug is used for sea sickness. So it is used whenever a person is traveling through your sea. Okay, and then you have another drug which is your cinnarizine. This cinnarizine, it produces its action by inhibiting your, it inhibits your influx of calcium from your, okay, next drug is your cinnarizine. This drug, it inhibits your influx of your calcium from your endolymph in your ear. Okay, from your endolymph in your ear into your vestibular sensory cell. So inhibition of influx of calcium is going to inhibit your impulse, thereby it is getting inhibited. Okay, so this is all about your H1 antihistaminic. Next comes your neuroleptics. So whenever we talk about your neuroleptics, generally in neuroleptics are used for a treatment of psychosis. Now your older neuroleptics such as your phenothiazine, haloperidol are potent antiemetics as well. Okay, so they are highly potent antiemetics, and basically these drugs, they show their action by blocking your D2 receptors in your chemoreceptor trigger zone. Okay, they block your D2 receptor on your chemoreceptor trigger zone, as well as they are able to antagonize your action of your apomorphine induced vomiting as well. Okay, they can stop your, if someone has taken apomorphine and they are continuously vomiting, so these drugs can stop your apomorphine induced vomiting. So they have other action, so they can act by blocking your antimuscarinics. They block your antimuscarinic receptor, or they block your muscarinic receptors, as well as they have certain H1 antihistaminic property as well. Okay, Okay, let's see drug. Okay, so these drugs, they act on your, I said they act on your D2 receptors on your CTZ. So since it is it goes and it blocks your D2 receptors on your CTZ, they can be used for treating your emesis induced by chemotherapy. Okay, they can be used to treat your emesis being produced by your chemotherapy during cancer, but they are not the choice of drug to be used in case of chemotherapy induced emesis. Okay, and these drugs are less effective in case of your motion sickness. Okay, they are less effective in case of motion sickness. They are less effective in case of motion sickness generally because there is no involvement of your D2 receptors whenever we talk about your motion sickness, and it generally acts on your CTZ. So what are it used for? It can be used for drugs in drug induced post-operative nausea and vomiting. Okay, it can be decrease your disease induced vomitings such as your gastroenteritis, uremia, liver disease, migraine, malignancy. Okay, even during your cancer chemotherapy, I said can be used for your cancer chemotherapy induced vomiting, but it is not generally your choice of your drug. Okay, it can also be used for radiation sickness vomiting, but it is very less effective, and it is generally not used in case of motion sickness, and should be used only in case of hyperemesis gravidium. Hyperemesis gravidium is generally a condition in which there is vomiting occurring, uncontrollable vomiting occurring in a pregnant lady during your morning time, and they are very less active in case of your motion sickness. Okay, so next we come to your 5-HT3 antagonist. So when we talk about your 5-HT3 antagonist, there is one drug. Okay, prototype of a drug is your ondansetron. So generally, since it is a 5-HT3 antagonist, they are going to act on your 5-HT3 receptor. So if they go and act on your 5-HT3 receptor, it is going to block your depolarization action of your 5-HT, which is your serotonin, which is exerted through your 5-HT3 receptor on vagal efferents in your GIT as well as in your STN and CTZ. Okay, so you can generally say these drugs, they have both your peripheral role action as well as your central action. Peripheral action, why? Because peripheral action, as you can see, they are acting on your 5-HT3 receptors present on your vagal efferents. These efferents are present in your gastrointestinal tract. So another, when we talk about central, it is acting on your STN and CTZ. Okay, so both your STN and CTZ is present in your central portion. Okay, so it has both your peripheral effect as well as your central effects. Okay, so whenever you are being treated by any cytotoxic drugs or radiation procedure is going under your cancer, what they do is they are going to cause vomiting. Okay, normally this vomiting is being caused because whenever you take these drugs are toxic in nature, so they are going to damage your cells as well present in your gastrointestinal tract. So whenever there is damage to any gastrointestinal to any cells, it is going to liberate 5-HT. So 5-HT is serotonin, so 5-HT is going to get released from your intestinal mucosa. Due to this 5-HT release of your 5-HT, it is going to activate your 5-HT3 receptor present on your vagal efferent in your stomach. So after it gets activated, it sends an emetogenic impulse to your STN and your CTZ, and then there is a induction of your vomiting. Okay, and generally these class, okay, your class of drugs under 5-HT3 antagonists, these are your drugs of choice for your chemotherapy induced emesis. Okay, so these are your choice of drugs. Okay, so same thing, ondansetron is going to block your impulses both at your peripheral origin as well as their central relay. Peripheral because your gastrointestinal tract, they have your 5-HT3 receptor. Whenever there is any damage to your cells in your gastrointestinal tract, it is going to liberate serotonin. Serotonin is normally going to activate your 5-HT receptor. So in this case, it blocks your 5-HT3 and your central relay. I said in case of your central relay, you have your CTZ as well as your STN. So STN and your CTZ, they both have your 5-HT3 receptors. So if they block your 5-HT3 receptor in your CTZ and your STN, you are blocking your impulse. Okay. Apomorphine or motion sickness induced vomiting is not suppressed, so it is of no use in case of motion sickness or any drug induced vomiting, that is apomorphine induced vomiting. So your main choices for your chemotherapy or radiation therapy induced vomiting. Okay, this is your main choice. One thing is this drugs, okay, 5-HT3 receptor, or you can say your ondansetron, also inhibits your cisplatin induced emesis. Okay, it is also useful in your cisplatin induced emesis. Induced emesis. It is also highly effective in case of postoperative nausea and vomiting, and or disease or drug associated with vomiting as well. So these are your basic functions associated with vomiting as well. So okay, the other drugs under your 5-HT3 antagonist. Okay, another drug is granisetron. When we talk about granisetron, this granisetron is 10 times more potent than your ondansetron. Okay, otherwise all your other action is same. Okay, granisetron. Apart from that, there is one drug which is a palonosetron. Okay, this drug palonosetron is compared to all your other drugs, it is a very long acting drug, and this drug has your highest affinity for your 5-HT3 receptors compared to all your other drugs. Palonosetron is long acting and it has a very high affinity for your 5-HT3 drugs, and this is the only drug which is approved by your FDA for your chemotherapy induced nausea and vomiting, that is your delayed chemotherapy induced nausea and vomiting. So after chemotherapy is done, vomiting or emesis can occur after 3 to 4 days. Since this drug is very long lasting, it can be used and your action can be shown after 2 to 3 days. So it can be used to block your chemotherapy induced nausea and vomiting in case of delayed cases of chemotherapy induced nausea and vomiting. But this drug, that is your palonosetron, should not be given along with moxifloxacin. It should not be given along with moxifloxacin, erythromycin, because whenever they are given along with moxifloxacin and erythromycin, it gives a QT interval prolongation, so arrhythmias can be developed. Okay, so it is not to be given. I think like one more drug which is not in there in the list is one prodrug is present in case of a 5-HT antagonist, and that prodrug is dolasetron. Okay, dolasetron is a prodrug which after metabolism produces hydrodolasetron by getting okay, this is a prodrug dolasetron. It gets metabolized to give you hydrodolasetron. Okay, and this metabolism is normally brought about by carbonyl reductase. Okay, so this is a prodrug that you see in case of your what you see in case of your drug. Okay, your prodrug in case of your 5-HT3 antagonist. Okay, when we come to your, yeah, I think it's better we do it here only. Your adverse effects of your ondansetron. Okay, normally your common adverse effects that you see in case of your ondansetron is constipation is there. You can produce diarrhea. There's production of your headache, and then you have your light headedness. Okay, these are your common side effects or your adverse reactions. That is constipation, diarrhea, headache, and light-headedness. When it is given through your IV injection, you can see hypotension can be produced, bradycardia can be produced, as well as there can be induction of your chest pain. So these are your adverse effects of your ondansetron. Okay. Next class of drugs is your prokinetics. So prokinetics generally they promote your GI transit time. It increases your transit times of your GI. Normally it increases your GI transit time by increasing your peristaltic movement. So it increases your peristaltic movement, as well as it is going to increase your gastric emptying time from your stomach as well. So this normally occurs by increasing your peristaltic movement of your GI tract. So one of your drug which comes under your prokinetic is a metoclopramide. So metoclopramide shows its action generally on your upper GI tract, that is your upper GI tract, and it increases your gastric peristalsis while relaxing your pylorus, thereby upper GI tract along with your first part of your duodenum, due to which there is an gastric emptying time is reduced. No, sorry. Okay, this is, I think over here there is a mistake. It does not reduce a gastric emptying time. Oh yes, it reduces your gastric emptying time. I'm sorry. Okay, so because of your increase in your peristaltic motion in your stomach, as well as relaxing of your pylorus and your duodenum, what happens is it reduces your gastric emptying time. So your food does not stay in your stomach for a very long duration of time. Okay, so it is an effective antiemetic drugs. It acts on your CTZ and can also block your apomorphine induced vomiting. So your metoclopramide acts by it has different mechanism of action. First and foremost, it has a 5-HT4 receptor agonism. This is an agonist of your 5-HT4 receptor. Okay, so it goes and it acts on your 5-HT4. How this helps in increasing your peristaltic movement is activation of your 5-HT4 receptor will cause release of your acetylcholine through your myenteric motor neuron. Myenteric motor neurons into your GI tract. So as we know, acetylcholine, whenever acetylcholine is released in your GI tract, it is going to increase your motility of your gastrointestinal tract. So whenever your metoclopramide goes and acts on your 5-HT4 receptor, it activates your myenteric motor neurons. So these motor neurons, they liberate acetylcholine in your gastrointestinal tract. So after it goes into your gastrointestinal tract, it is going to increase your motion in your gastrointestinal tract. Second is vagal antagonism. In this case, this vagal antagonism is occurring for your efferent vagal neurons, which goes to your sends impulse to your CTZ and your STM. Okay, so it blocks your impulse. It is a vagal antagonist. So it blocks your impulse going from your vagal efferent neurons to your CTZ and STN. Thereby, it stops your signal from your gastrointestinal tract going into your STZ and your CTZ. Third is your 5-HT3 antagonism. So, in case of 5-HT3 antagonism, this 5-HT3 antagonism is generally a central action. Okay, so it goes and it stops your signal for being signal in your CTZ and your STN, which acts through your 5-HT3 receptors. And fourth one is sensitization of your muscarinic receptors. I already told you your metoclopramide goes and activates your 5-HT4 receptors. Due to activation of your 5-HT4 receptors, there is more deliberation of your acetylcholine. So acetylcholine is sensitizing your muscarinic receptors, so due to which there is increased peristalsis. And lastly, it has some dopaminergic receptor antagonism. Okay, dopaminergic receptor antagonism. So it acts through your goes and it blocks your D2 receptors. D2 receptor is generally inhibitory in nature. So whenever D2 receptors is being inhibited, it in turn tends to increase your peristaltic movement. Okay, so it increases your peristaltic movement, due to which you have a increased peristaltic movement occurs. Okay, so this is all about your metoclopramide. Apart from that, this metoclopramide, it can be used for your gastroesophageal reflux diseases. Okay. Your metoclopramide, it interacts with absorption of different drugs, so it increases absorption of your aspirin and diazepam, but it decreases your bioavailability of your digoxin, and your digoxin is inhibited, and cimetidine, it inhibits your it decreases your bioavailability of your digoxin and cimetidine. Okay, when we talk about your adverse effects of your metoclopramide, metoclopramide, whenever it is used for a very long duration of time, it can induce drug-induced Parkinsonism is seen. Drug-induced Parkinsonism is one of your adverse effects of your metoclopramide. Other adverse effect is galactorrhea. Okay, gynecomastia is there. Okay, so these three are more important side effects of your metoclopramide. So metoclopramide is going to produce Parkinsonism, which is your drug-induced Parkinsonism. There is galactorrhea. Okay, high secretion of your milk. Okay, there is gynecomastia, which is development of your male breast. Okay, these are your side effects. Other side effects are same, like sedation is there, dizziness is there, constipation, and muscle dystonia may be seen whenever you use your metoclopramide. Next class is D2 receptor antagonist. So your drug is your domperidone. So domperidone, when we talk about domperidone, this drug domperidone has action only in your D2 receptor. It does not have any antihistaminic action. It does not have any anticholinergic action. The only action your domperidone shows is D2 receptor antagonistic action. Now, your prokinetic action is basically because it goes and it acts on your D2 receptor. Okay, it acts on your D2 receptor and blocks D2 receptor blockage occurs in your upper GI tree. But your major antiemetic action of your domperidone is usually seen, okay, is not due to your D2 receptor blockage in your upper GIT. Is basically because of your blockage of your because of your blockage of your dopaminergic receptor occurring in your CTZ. Okay, main antiemetic action is because of its action on CTZ and not because of your blockage of your D2 receptor in your GIT. So action of your domperidone on your GIT will increase your peristaltic movement, will have a prokinetic effect, but major antiemetic effect is because of its action on your CTZ and not on your D2 receptor on your GI tract. Okay. Domperidone, it does not cross your blood-brain barrier. Your bioavailability is very less. Okay, and your side effects that you generally see is dry mouth, loose stool, headache, rashes, galactorrhea is there, but it is generally mild. So cardiac arrhythmias may be developed whenever you use your IV injection. Before we go into your neurokinin receptor antagonist, there are again other few drugs. Your other drugs in this case is your cisapride. Okay. In case of cisapride, your cisapride does not act by going and acting on your D2 receptor. Okay, your main mechanism of action of your cisapride is basically by going and acting on your 5-HT4 receptor, and by acting on its 5-HT4 receptor, again, as you know, acetylcholine is being liberated, and because of liberation of your acetylcholine, it is going to increase your peristaltic movement. So its main action is by action on your 5-HT4 receptor, but it has little effect on your 5-HT3 receptor as well, but it is very weak. Okay, and in comparison to your metoclopramide and domperidone, which acted only on your upper GIT, this drug generally does not act on your upper GIT. It acts on your lower GIT in your region of your colon. So it increases your motility of your colon. Okay, it does not act on your upper GIT, it acts on your lower GIT. Along with that, this drug also, it induces your secretion of your chlorine ions from your colon. Okay, so it is going to induce your secretion of your chloride ion through your colon. But since because of your safety issues, this cisapride has been banned. It has been banned because it has a tendency of creating arrhythmias. Severe form of arrhythmias are produced whenever cisapride is used. Second drug, which is your mosapride. This mosapride is still in use. Okay, it does not produce your arrhythmia generating property of mosapride is very less. It is in use. Lastly, you have your drug, which is your etopride. Etopride has different mechanism of action than your cisapride as well as your mosapride. Your etopride mechanism of action is D2 antagonism. So see again, D2 antagonism, it is going and acting on your GI tract. D2 receptor is inhibitory in nature, so it inhibits your action. So it generally increases your motility. Okay, second is anticholine. It is also anticholine esterase. Okay, it goes and it blocks anticholine esterase. Since it is blocking your anticholine esterase, your breakdown of your acetylcholine will be reduced. If your acetylcholine degradation is reduced, acetylcholine will be present for a longer duration of time, so it can show its action for a longer duration of time. Thereby your motility or your peristaltic movement of your GI tract will be increased for a very long duration of time. And it does not promote any QT prolongation. It does not produce any arrhythmias, that is your etopride. Next you have, I think it is your neurokinin N1 receptor antagonist. That is, your drug is your aprepitant. Your aprepitant is your neurokinin 1 receptor antagonist, and it has a very high affinity for this drug. So neurokinin 1 receptor is generally activated by substance P. So aprepitant goes and blocks the action of your substance P on your neurokinin 1. Generally this drug is used in combination with other drugs such as your 5-HT antagonist and corticosteroids. Okay, so it is used in combination with ondansetron, as well as it is used in combination with dexamethasone. Okay, it is used in combination with ondansetron, and it is used in combination with dexamethasone, and it is generally used for your treatment of your acute and delayed chemotherapy induced nausea and vomiting, as well as for prevention of your post-operative nausea and vomiting. So this is about your neurokinin 1 receptor antagonist. Okay, apart from that, you have, okay, going on to you have your adjuvant antiemetics. Okay, you have different adjuvant antiemetics. Okay, so adjuvant antiemetics are not used individually. Okay, they are generally used in combination with other antiemetic drugs. Okay, so your adjuvant antiemetics may either be your dexamethasone, okay, which is a steroid, benzodiazepine, which produces its effects by sedation, and dronabinol and nabilone. These are generally your cannabinoids. So they are your adjuvants. They are used along with combination with other drugs. They are not used singularly. Okay, so see your primary agent and your supplementary. So this over here, these are your adjuvants being used, okay, in combination. Okay, useful combination of your antiemetic drugs for improved antiemetic effects. Okay, these are, and lastly your different types of different class of drugs, your example of your drugs, and then your most your type of vomiting that it is most effective against. Okay, so you can go through this chart as well, and I think with this we complete your topic, which is your antiemesis or antiemetic drugs. Okay, thank you everyone. Hope you guys are studying. Please study